Hello, everyone. Good afternoon to you. Welcome to today's webinar, Responding to the Fentanyl and Xylazine Crisis in partnership with the San Bernardino County Department of Behavioral Health and Department of Public Health. I'm Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society. For those who participate in the entire webinar, you're eligible to receive 1.5 CME credits thanks to our partnership with Loma Linda University School of Medicine Continuing Medical Education Program. Each of you has received an email with the form needed to apply to claim your credit, and we'll send that out again immediately after this webinar. You must apply by 5 p.m. today. That's your deadline to apply for your CME credit, okay? So if you have any issues with that, reply to our email, or you can email any of us we'll make sure we put that in the chat. Soteria, why don't you pop your email in the chat right now, if you would, please. Before we introduce our presenters, we just want to remind you to keep yourselves on mute, if you would, so that we can have a nice audience for our presenters. And we will also be taking questions following the presentations. So feel free to go ahead and submit your questions throughout their presentations on the chat feature on Zoom. And if you'd like, when we're finished, you can also raise your hand and we can make it interactive. That's just fine. So with that, let's get started. And we have a lot of attendees today. This is a really well-attended event. So we really appreciate everyone being here. This is a really valuable and timely subject. So here we go. I'm very pleased to introduce our first presenter, Michael Sequeira, MD, Public Health Officer for San Bernardino County and ER physician leader for many decades. For the past 30 plus years, Dr. Sequeira has worked in leadership roles at the local, state, and national levels, including as regional director of 6 of the hospital emergency departments. He's past president of the San Bernardino County Medical Society in 2016-2017, and currently serves as a delegate to the California Medical Association's House of Delegates through our medical society locally. He's a member of the steering committee and the founding member of the Inland Empire Opioid Crisis Coalition, where he remains instrumental in developing much of their outreach and programmatic focus. He also serves as National Risk Director for Vituity Healthcare. Welcome, Dr. Sequeira. We also want to introduce Jonathan Avalos, MD, Associate Medical Director, Department of Behavioral Health, San Bernardino County Substance Use Disorder and Recovery Services. Dr. Avalos grew up in Glendora, California. He completed his undergraduate and medical school in Houston and a residency in family medicine at Harbor UCLA. While a resident, he was the first physician to prescribe buprenorphine for, did I say that right? Buprenorphine for opioid use disorder at his training clinic. He went on to complete the fellowship in addiction medicine at the Betty Ford Hazelden Center in the Coachella Valley, and has worked for San Bernardino County Department of Behavioral Health for 5 years, building their programs and expanding collaboration across departments. He's also an expert reviewer for the Medical Board of California. With that, we will turn it over to both of you, and thank you so much for joining us.
Thanks, Allison, and thanks to the Medical Society for giving us this opportunity to reach out to you. And it's my pleasure and honor to have Dr. Avalos co-present with me. And we needed some beauty, so we decided to. But it wasn't just beauty; there's brains there too. So Dr. Avalos is one of the premier experts on substance use in our county, and I'm so proud of him. And it really is an honor to co-present. John.
Well, thank you all for having me again. It's been a pleasure in this journey from a contract physician doing physical exams 5 years ago, building the MAT, and now a lot of outreach. And it is just a pleasure to be here and to be presenting with a colleague and a friend.
Great. Oh, thanks, John. And so I'm going to share my screen now, and I just need okays that this is coming up. People keep trying to come in. So you guys see my screen now? The slides? Yes?
Yes, it looks good.
Yes.
Okay, great. So one of the things, and thanks to Loma Linda for giving us these 1.5 units. As you all know, and I'm going to jump off first in terms of the scope of this seminar. We're really intending to to make this an 8-hour series, and we started with just an update, but when I suddenly realized, because we started getting people asking, do we get the 1.5 hours and do they apply to our 8-hour requirement? So so that it also hit me simultaneously that when to prescribe buprenorphine prior to a year and a half ago, you needed what's called an X waiver to be in that X waiver. To get your X waiver, you needed 8 hours of training in MAT and substance use disorders. So a year and a half ago, we lobbied. Medical Society was behind that, and actually were successful in eliminating the need for an X waiver. But at the same time, as corollary to that, it imposed an 8-hour requirement that one-time requirement that physicians do 8 hours of continuing ed and MAT and opioids. So we're intending to make this a series, and it'll include obviously this 1.5 hours, and then and John, what do you think? We're going to talk about MAT, right?
Yes, we're going to cover
future series.
some of the items related to this. So this is kind of an overview and introduction, but medication-assisted treatment, which, as Mike said, is available for anyone who's willing. We're going to cover some of the community resources that are out there for your clients. I think focusing on treatment and really what that looks like for somebody in that experience, so that we can discuss that.
Right.
And then
and I want to throw in I get real granular and scientific too. There's a lecture I give to the medical school on opioid receptors and all the pain pathways, as well as then getting into some basic pharmacology of all opioids as well, which I think would make buprenorphine make more sense too. And then what Dr. And the other thing I think that Dr. Avalos and I had been talking about was that inpatient management of people who are in fentanyl, detoxing them is a nightmare. And John and I basically were talking about how difficult that is. And then when you throw in the fact that they might have xylazine withdrawal too. So I'd like to be able to we'll include that as well, just with detox and withdrawal issues in opioid and xylazine. So I think we'll easily fill that 8 hours, and it should be really, really good and instructive. And then and the nice thing is it should satisfy everyone's requirement. So today, what we wanted to do is just review the impact of fentanyl, discuss the nature of fentanyl use and xylazine, and we'll dig deeper into xylazine pharmacokinetics and the toxidrome, a little bit more on opioid use disorder. You notice one of the things I want to make sure that everyone doesn't use the words abuse or as much as addiction. The terminology is really important, and we'll explain why, but it's part of harm reduction and destigmatizing. But you see opioid use disorder. It's not opioid addiction or opioid abuse, okay? And so we're going to talk about that, talk more on harm reduction. I don't think we'll be able to get to new regulations, and I think we'll probably add that. There are more and more regulations pending about fentanyl. And then I think Dr. Avalos and I will provide some of the resources in the community to basically help us on how to combat this challenge. John, you want to take this one? What is fentanyl?
Yeah, absolutely. So fentanyl is a synthetic opioid, and if anyone has a background in anesthesiology, you are very familiar with this medication. But for those of us who may not be, fentanyl is a synthetic opioid. It's 50 times stronger than heroin and estimated to be approximately 100 times more potent than morphine. And what we found over the last 5 years is this is an increasing contributor to fatal and non-fatal overdoses, both in our state and across the entire country. with that increase, we've actually seen something come from the CDC here that they have not done in the past. So historically, the statistics were all really retrospective. And in this case, the CDC is now giving us a prospective estimate of deaths. And unfortunately, we are seeing a continued increase, but the rate of increase is declining. And so some of the efforts that we've made that we'll go into in greater detail later in the presentation are working. And what I really like here is if you look at the deaths by quartile in 2021, we see this flattening of the curve in the middle of this purple box. But unfortunately, 109 deaths estimated for the year ending February 2024, or excuse me, 2023 would be an increase over the prior year.
Yeah, and what's interesting too is, what do you think, John? I wonder, many of the overdoses were not diagnosed because they weren't testing for fentanyl at the time.
Right.
So, great.
So as Mike had mentioned previously, not all overdoses are fatal, and estimating non-fatal overdoses is also a part of this. And if you can frame this in the context of hypoxic brain injury, right? You can imagine a drowning, right? A period of time as brief as 2 minutes, right? In which the brain is not receiving adequate oxygenation. You may have seen patients with this condition, and they may have cognitive delays, they may have memory issues. And in the Department of Behavioral Health, we see some folks that have more impulse control or behavioral issues. There was a study of suspected non-fatal opioid overdoses, and effectively, they're finding that fentanyl is a huge contributor of these. And what you actually, I apologize that the text is quite small. There are a number of other issues as well, including prescription opioids. But over time, from 2018 to 2022, that has become a decreasing issue. Next slide.
Excuse me, I don't mean to interrupt. Dr. Sequeira, if you have control of the slides, is there a way you can put your slides in presenter mode? I'm not sure which button it is at the top that you click, but it's showing all your other slides, and we're getting some comments in chat that it's difficult to see.
How's that?
There we go. You got
Thank
it.
you. Thank you, whoever
Thank you.
pointed that out. We were having some technical problems.
Thank you so much. So this is another one of my slides, and unfortunately what we see here is this visual depiction of the opioid trend, really with a dramatic increase occurring around 2018. And we do see kind of a mirroring of that shape as the curve approaches 2021. We see somewhat of a flattening of that, with CDC statistics estimating drug overdose deaths responsible for approximately 106,000 deaths in the US. I'm going to bring your attention to the second point here, and this is quite interesting, and this came as a bit of a surprise to me, actually. And that is adults age 65 and over actually had the largest percentage increase in the rates of death between 2020 and 2021. Going to the fourth point, the rate of drug overdose deaths involving synthetic opioids other than methadone increased 22%, right? While the rate of deaths involving heroin actually declined. And so we're seeing potentially some good news in a reduction of heroin use and heroin distribution and overdoses related to that. But unfortunately, that's being replaced with the synthetics. And we're seeing that specifically affecting older adults. And if you draw your attention to the gender split between male, female, and total, this is affecting males 65 and up specifically.
Although I always tell my wife, don't genderize things, but looks like we're going to genderize here. And
yeah, well, let's blame the
sucking
CDC
right
for
now.
that one a little bit. But in terms of the way that the data is reported, they do see a gender split there a little bit.
Yeah, it's really interesting. And take note of that. We'll come back to it. Age 65 and over, largest increase. Okay. Now I'm going to take you back to San Bernardino County and look at this on the graph. We mirror California, and it really pretty much mirrors the U.S. In 2018, there were only 30 fentanyl overdoses in our county. The number rose to 74 in 19 2019, 227 in 2020, and last year 309, and we're on pace this year, slightly lower, just like Dr. Avalos had mentioned that. I'm hoping that some of our stuff is working, but there's also this new trend, the new trend in rainbows. What, John, you want to make a comment on that, or?
Right. So in terms of the form, one thing that's really interesting, I walk a lot to try to manage that sort of post-COVID weight, right, and practice what we preach as a former primary care provider. And I used to see in the area needles, spoons, devices related to injection drug use. And what's really interesting is I've seen less and less of that over the last 2 years. And so there's been this transition away from injected heroin as we've shifted to the higher potency synthetics. It's really smoked more and more. And so the route has changed. And where Dr. Sequeira sits, right, in terms of the implications on infectious disease, there may be some positive effects of that transition in route. But unfortunately, with the increase in potency, we're seeing an increase in the deaths. And so what does this look like? Well, this looks like synthetic powdered product in a high potency form, according to the DEA, being exported in smaller packages into Mexico and other places, and being pressed into a pill. Now, unfortunately, for those of you who may have worked in anesthesia, right, or critical care where you would use fentanyl in a medical setting, right, that's dosed in micrograms, extremely closely monitored, right? Well, you can imagine somebody in a garage with a pill press cranking out different colored pills, right, does not operate with the same level of precision.
And those pills look like sweet tarts. But they're designed to look like M30s, which are the OxyContin pills. And so we're seeing this wave of overdoses in people who are just experimenting. They're teenagers who basically they're going to parties and trying to just get high with M30 OxyContins, and they're dying. And this is reviewed. This is really interesting because I was really involved with IEOCC and opioids for the heroin and the first two waves, the prescription wave and then the heroin wave, and then the fentanyl wave. And when I came on as health officer, we do a monthly children's death review, all unnatural deaths in San Bernardino County. The striking thing is that this is what we found in this age group, 15 to 17. The number one independently identified cause of death in San Bernardino County for ages 15 to 17 is fentanyl. So I mean, you can just see. I mean that and these are kids usually that aren't usually taking don't have opioid users or aren't taking fentanyl regularly. And just to point out what Dr. Avalos John was saying too, the users, when you interview them, they prefer the fentanyl because they don't have to inject, and it's automatic harm reduction in that way because we don't get as much HIV, Hep C, and MRSA, and endocarditis, and spinal epidural abscess. All of those harm secondary effects of intravenous heroin use are going to go down. So I see Dr. Veltman's on this call, and maybe you won't get as many patients anymore, Dr. Veltman. But we're getting them because they're dying, and especially the young people and the other. But this was just from the CDC in January. Fentanyl drives a startling increase in adolescent overdose deaths. And you know what the interesting thing about this is? Look at the bottom where I have with the 3 stars. Bystanders were present for 2/3 of the overdoses in this age group. In most cases, they didn't know what to do with life-saving care. If they would have had Narcan at that party, 2/3 of those overdoses in adolescents, there were witnesses right there in their age group. So this gives you a target of what we have to do, because you can't just target people with chronic opioid use. I brought in these statistics because these are statistics showing that chronic SUD is substance use disorder in teens is going down. See, second bullet, teen drug and alcohol use is in decline. And the third bullet, between 2 and 22, the share of 12th grade students who used illicit drugs dropped from 21% to 8%. So we're making progress in this. And the share of 12th grade students, fourth bullet, drinking alcohol dwindled from 72% to 52%. And yet, in spite of all that, we're seeing skyrocketing adolescent teen overdose deaths. And there's only one underlying factor. It's the fentanyl. And I'm going to have John bring back this point too.
Right. So again, not to dwell on this too long here, but we do see really this bifurcation in the very young people experimenting with drugs and in the older adults experiencing fatal overdoses as well. And this has been over really the last few years, as you can see in this tale here. So,
John, what's some of your theories on why older people? I mean, they're not like suddenly going to use drugs, right?
No, exactly right. They have that nice myelinated prefrontal cortex, right? They've gone through their teen years. But I believe that the thing that's changing is not necessarily the individual user, right, or the client. What's changed is the drug supply. And so, up here in Barstow, I have many people that have been chronic, users of illicit opioids, and they had, a stable supplier. They had a routine, right? Like a lot of us develop by a certain age, right? But unfortunately, what's changed is the supply. And I have many chronic heroin using patients coming in and seeking medication-assisted treatment or help in residential treatment because the drug supply has changed and they can't get the drugs that they've used for so long.
Interesting. And do you think they're chronic pain patients or opioid use disorder patients? Or?
Talking to a lot of folks, that's a great question, Mike. Many of them get started in chronic pain, and where we have shortage of treatment or a number of other factors, right? Folks can transition from chronic pain and opioid dependence, right, into really using it for other things, right? It becomes a coping strategy, right? We had maybe a emotional conflict, maybe we have some depression that's untreated, and it becomes that coping strategy. And that's where that very subtle transition goes from chronic pain into problem use. But unfortunately, what we're seeing is accelerated deaths.
Yeah, and one in our series, I'd like to do, the CDC has new guidelines for treating pain. They talk about low-dose naltrexone now for chronic pain and things. And so I'd love to have a segment of that on treating chronic pain, which is really kind of neuropathic stuff. And I just wonder, CBD is everywhere, even on the street. What do you think about that? Do you think, they're lacing illegal pills like M30s, and maybe CBD is being laced too? It's not something that's certified and FDA cleared.
Right, and that would go back to supply, right, and the contaminants, right? What contaminants are we putting ourselves at risk for with certain supplies? And so this is a conversation I'll often have in the context of motivational learning, right? Okay, where is this coming from? What are the circumstances of production, right? Where are they getting their supplies from? And we start to introduce doubt regarding the quality of a drug supply. And I think that's one point where we can start to then bring in the alternatives and say, hey, we may offer something safer that may allow you to continue to feel okay.
Excellent. Hey, you mentioned something, and I learned as an ER doctor and internist, motivational interviewing.
Yes.
briefly, can you share what that is to our audience?
Absolutely. Well, I would say briefly, that's my secret weapon here, right? That's the secret sauce that a lot of us in the addiction medicine, addiction treatment world rely on very much. And really, this is a process of inquiring into the reasons for and reasons against. And the goal is really to develop ambivalence and help that person move towards positive change. As a doctor, what does this feel like? This felt like such a relief, Mike, when this was introduced in part of my practice. Once upon a time, I felt like I was in a tug of war with people trying to reduce their, Norco doses or their, Percocets that they'd been on for a while, right? And it was exhausting. And I felt like when I started using motivational interviewing, something changed. And I feel like I was pulling on the same side as the patient, and we were pulling together against a problem. And that would be potentially something that we could include in the series as well.
Yeah, and I'd heard it also heard. I actually, when I heard about it, it was so fascinating, and it's great to hear about it from you as much firsthand. But I think isn't that part of it? You're actually empowering the patient to take control of their body,
Yes.
and you're motivating them. You own this. This is your body. This is your problem. Let's help you get through it.
Right, exactly. We allow that person to take responsibility for finding their own reasons and for finding their own solutions to this problem.
That's cool.
It works.
Yeah, and there's a lot of literature now, and once I started realizing it, that on the positive effects of motivational interviewing, and actually for those of you non-substance use physicians and in the community, look into this. This is really something. If motivational interviewing is effective for alcohol, it's effective for compliance with your antihypertensive or type 2 diabetic medications, anything like this in terms of enforcing compliance from your patients, getting them more involved. So glad you brought that up. Great. Okay, so John, this one's yours.
Right.
You want
So I'll just cover this very briefly. One of the other complicating factors that we have, again, we're primarily talking about opioids, synthetic opioids, and fentanyl. But as you all know, there's a synergistic effect in terms of developing respiratory depression when a benzodiazepine is involved in somebody who is also taking an opioid. And one of the things that concerns me greatly, particularly with younger, maybe more tech savvy adolescents and young adults, is the role of high potency illicit benzodiazepines. Typically, these are purchased through the dark web on the internet. And if you look at the number of non-fatal overdoses involving illicit benzodiazepines, many of these are not prescribed. So these are drugs that would not generally test positive on a conventional ELISA drug screen. And so my point with this is really don't be afraid of sending a more extensive panel of drug screen. And I would also say, even if your drug testing is showing negative, go with your clinical judgment, right? If you suspect there's problem use, there are limitations to the testing that may exceed what your lab can test for. Thank you.
Yeah, and actually, it's amazing what's on the street too. Things like Xanny bars are free. That's Xanax. Those are brownies laced with Xanax, and so the benzos are, they're interested in just making their customers feel the high. So they throw in anything from the kitchen sink that they can probably kind of do that.
Well, what's so concerning about that is with some of that illicitly produced Xanax, in one particular case I cared for a few months ago, the drug was actually flualprazolam. And what is the potency of that, right? Relative, what are the pharmacologic characteristics of that, and how does that interact with other medications, right? So much of this is unknown, and so I think that your clinical discretion is incredibly important, even when the testing hasn't quite caught up with the technology out there and the use of drug patterns, particularly in the more tech savvy young adults.
Yeah, and I can imagine when you're detoxing, if you don't have a full picture, it can really screw things up and make it more difficult. And you can imagine people with trauma, people who have all these in their systems, they have use disorder, and they come in, they're intubated, they had their trauma surgery and they're in the ICU, and suddenly they're going, your vital signs are just shooting off the board. And so that's why it's important that even trauma surgeons need to know this stuff, because I've been encouraging Dr. Avalos to start a withdrawal, a detox service for the hospitals and as well. So this brings up what the Society of Study of Addiction it labels the next OD wave, and it's not just benzos, but also, when you talk about San Bernardino County, unfortunately, you have to talk about meth, right? And I know Dr. Avalos, John, and you've talked to me about a few of your studies approaching meth as well, but this slide basically shows what they're calling the fourth wave is fentanyl plus stimulants. And
Yes.
the first wave was overprescribing opioids, which was our fault, right? And because we had no standards in prescribing, et cetera. And the leftovers created dependence, and that led to wave two, the heroin epidemic, basically, which then led to wave three, which is we're in the middle of fentanyl, and wave four they're saying is fentanyl with stimulants. I don't know. Do you think that's kind of artificial, John, or?
I think there's actually two parts to this
Uh-huh.
in terms of the fentanyl with stimulants. Not to use too much street language here, but sometimes there's something called a speedball, and you may have heard of that in the 80s and 90s, right, where there was intentional use, right, of a stimulant with heroin, right, and the point of that is right, to kind of balance that effect and also to extend the duration and the euphoric effect. And there's something more recent called a goofball on the street, and that is essentially methamphetamine combined with an opioid. So some of that, again, may be intentional to mitigate the effects of respiratory depression and to prolong the euphoric effects of that combined drug combination. But I think the other part of this is unintentional. Right, if we go back to contamination, and if we envision a client, say here in the high desert where I sit today, who was a chronic stimulant user and did not use opioids, right, prescription or otherwise, and now that individual, through changes in the drug supply, is exposed to maybe a 3 milligram accidental ingestion of fentanyl, right? You can imagine, that may be a fatal overdose right there out of the blue. So unfortunately, I think this problem does cut across our traditional distinctions of populations.
Yeah, and it actually brings up the whole issue of substance use disorder and dual diagnoses, right? I know that DPH, we talk about it a lot, but it's not just for another substance. It's also because of the psychiatric DSM issue.
Right. So a lot of what we'll do here, DPH is really the concurrent treatment of either a persistent and severe mental illness, or perhaps in some cases a less severe mental illness that may trigger emotions in which somebody may not have coping skills. And that's where we see that interaction between substance use as an unhealthy coping skill, right, with a problem that may have a solution in psychiatry, therapy, or other behavioral treatment. So we really treat these two things simultaneously, ideally.
Yeah, and I think these drugs have various psychoactive secondary effects as well. So it really creates a diagnostic potpourri, I think, in many ways that you've just got to filter it out.
Right.
So so this is important for those of you who have a patient that you think you're detoxing or you're inducing with buprenorphine, and they're not acting like they should. And we'll bring in more of a case in in that regard. So back to confusion. One thing what we wanted to do, and we presented some statistics earlier in the talk, is I really wanted to get a good measure of exactly how big of the problem is, and actually we wanted to know as early as possible when we're having an outbreak. Like there's like, for instance, Sacramento a year and a half ago suddenly had 16 overdose, all young people, and all deaths. And we, there was a latency there, but boom, they put it all together, and it turned out to be the introduction of carfentanil, which is an elephant tranquilizer that's even that much more powerful than fentanyl. But so what I wanted to do was create some measure of the overdose problem in our county, to where, and I keep it's just I'm a broken record. I want actionable data. I want actionable data, and accurate as much as possible. So what we've done, we've actually combined with the IEOCC and DPH and public health, our data people, and who are we have a few ESRI people, ESRI people as well. We're just about to roll out an OD dashboard. It's going to be called OD Ash or O dash, and it's actually it's going to be state of the art. But when we really looked into this, right, the previous data source was California Opioid Provider Network, COPN, and that was all based on coroner's data. But the coroner's data that they got basically was not as accurate as ours. So we've been working with the coroners to really make this much more accurate, and to make sure that they're testing for fentanyl, because we'll get an undetermined death that sure looks and smells and sounds like fentanyl, but they're calling it an undetermined death. So we're really working with coroners. They've been wonderful. We've got a whole crew of new coroners, and we're making sure that we get testing for fentanyl, and recently pushing for the next medication, that drug that we're going to be talking about, Xylazine, as well. So so that's our current data, but there's also this thing called OD map, and it's a non-proprietary database, and it's run by the Maryland, Washington D.C. Group, and basically it takes ambulance data and shows you where the ODs are, in ODs and Narcan reversals as well. When we had our data frame, brainiacs basically look into this, our data is incomplete. So we're working on that, though, and we're going to work on getting basically the elements of ODMAP, which is ambulance call data, into this. So, and that can give me and us a lot more actionable, more recent real-time data. And the last thing what we were going to be doing is adding this to ReadyNet. Those of you who are non-emergency doctors, ReadyNet is every morning every hospital calls into the ReadyNet system, and the system is actually run and managed by the Hospital Association of Southern California, HASC, and that's how we do our syndromic surveillance, which is all the flu-like illnesses, we call ILIs. But what we've done is add to the ReadyNet reporting overdose and possible overdose and partially reversed overdose, to be able to add even more actionable, more recent real-time data. So that's coming, and with our next presentation, I'm going to have our data people make a presentation, and it should be open access, so that you should be, emergency docs, it's primary care docs, you should be able to look. And my thing, and working with Dr. Avalos and DPH, and we're going to work with the fire chiefs as well, and EMS, is to look towards getting a response teams. We got an outbreak. We've got 4 overdoses in the Bloomington, or in the Redlands, or in the Apple Valley. I'm not going to say other. I don't want to pick on any one area. But and then what we basically work on is an overdose response or harm reduction response team that we send out and just blanket that area with Narcan and information. So that's coming, and it's exciting because I it's really a pleasure to work with such smart people and doing that. So next thing is John, we're going to talk about intro Xylazine.
Yes, yes. So some of you may have been involved in there was a call, which I thought was really exciting. It was with the White House Office of National Drug Control. And what they described is an emerging trend, first detected in Puerto Rico and within the US, most focused on Philadelphia. What they found was something very unusual. There's a non-human veterinary tranquilizer that was being combined with opioids, specifically with fentanyl. And what the forensic toxicologists were able to determine is that this was xylazine. And so this is an adrenergic agonist used for sedation of animals. And the subsequently information that's come out is that this is used by street level distributors to prolong the effect, right? As many of you know, fentanyl, right, is a short acting drug. And so in order to mirror the duration of heroin, they're adding xylazine, which is very, very interesting. But unfortunately, because this is a veterinary drug, right, there's not a history of this being used in humans. The urine drug screens were testing negative for this, right? And in Philadelphia, what they found is that 90% of the illicit opioid samples were tested positive for xylazine as in combination with it. This has been found in drug seizures across 48 states. And there is a manufacturer now of a fentanyl test strip of a xylazine test strip to actually test for the presence of xylazine. Which is very, very important. So
Yeah,
I thought it was so cool. My takeaway, Mike, I don't know if I've told you this, from that conference was, here is somebody at the White House and they're saying, we have a problem. We don't know how to test for it. We don't know how to detox people from it. And we don't know how to treat people long-term for this, but we're going to find out. And the federal government committed on the order of, it was between 50 and $52 billion to investigate this problem as rapidly as possible.
yeah, I agree. And that declaration of emerging threat basically mandates a response, which is what you just talked about. So that's great. And let me go into some pharmacology as well. John mentioned it's an alpha-2 adrenergic agonist, like clonidine. Okay, a lot of people know clonidine because it's an antihypertensive. It's a centrally acting, and it's in the imidazoline family. So it's the original imidazolines were nasal decongestants like oxymetazoline, which is Afrin. So keep that in mind. So the ER docs like toxidromes, right? And sort of addiction specialists like Dr. Avalos. But this is the toxidrome basically for xylazine. There's CNS toxicity, there's areflexia, asthenia, ataxia, coma, okay, disorientation, what we call ALOC. You can actually it can actually elevate to seizures and hypersomnolence as well, and in lighter stages of people are staggering. There is respiratory depression, and I'm going to talk a little bit more about the skin ulcerations in a second. From a hemodynamic standpoint, these patients this is xylazine alone, by the way, get bradycardic and hypotensive. Okay, so usually when people get hypotensive, they get tachycardic. So when you see that combination and part of that toxidrome of brady and hypo, bradycardia and hypotension, that needs to figure right in, especially when you throw in ALOC. They're comatose and they're not breathing. And the other thing that makes it a little bit more specific as a toxidrome is hyperglycemia. Their sugars are sometimes into the 500-600s. Their glucoses. So John, you want to take this one?
Yeah, absolutely. So the route of ingestion is quite diverse. It's been smoked, orally ingested, snorted, injected, IM, subcutaneous, or even IV. And Mike's going to show us a little bit about what some of the consequences and sequelae of injection use can be. The half-life is longer than fentanyl. And again, the intention of that combination is a synergistic prolonging of the effect of the opioid. This is really weird. It's not regulated yet. That's coming. And I believe there are some state efforts being made to try to work more quickly than the federal regulators. Unfortunately, this drug is not reversed by naloxone. There was a question I saw in the chat flash, which is, how does naloxone work, right? So naloxone being the reversal agent for an opioid. Well, that is highly specific to the opioid receptor. And as Dr. Sequeira said, this is an alpha-2 adrenergic agonist, right? Will not be affected by the Narcan, unfortunately. So in terms of sympathetic effects, we would expect hypotension and bradycardia, hypotension responding to fluids and pressors. Again, so this is something that may be beyond the scope of like what I do in terms of outpatient treatment, or even some of our residential withdrawal management facilities. This may be really a hospital and potentially critical care involved syndrome, at least in its initial presentation.
Yeah.
In terms of the skin, Mike, I'm going to turn that back to you.
Okay, great. Yeah, and just quick, briefly, the hypotension usually is responsive to fluids and pressors like Levophed and dopamine, and the bradycardia is usually responsive to atropine as well. Of course, it can also be you can pace the patient as well, but it's usually pretty transient. One of the real characteristics of xylazine and that scares the people on the streets is the skin reaction. Okay, so this is a picture of it. This is credits given on the bottom. I got this from New England Journal, but they come in with necrotic skin reactions. A, B, and C are all from the same patient, but and D is in an arm, and you know, and it's necrotic, so, and avascular, so and frequently super infected with Pseudomonas aeruginosa and MRSA, but so this is really the street users are terrified of this, and it's really difficult to treat these because they don't want the doctors to know that they're on tranq or street drugs. So it's really difficult to get them treated for this. And it's, once you see this, it's it's crazy. You think flesh-eating bacteria, but it's it's xylazine. And the other interesting thing in this New England Journal article talks about that is that it's not just at the injection site. It can be smoking xylazine, and you can get it in its localized area probably of intense vasospasm, and to the point that the skin infarcts or dies. So you see this, that toxidrome with the hypotension, bradycardia, coma, respiratory depression, that's xylazine. Xylazine alone, not xylazine. And when you combine that with fentanyl, of course, it gets even more complicated. The other thing is, and back to our specialist, John, xylazine withdrawal. Talk about that some.
Right.
Mixed
So
withdrawal.
if we can imagine, right, so what would be the effects of like dexmedetomidine, right, another drug, right? It's a FDA approved, right, sedative, working in a similar, but certainly not identical way. And withdrawal can include that irritability, anxiety, dysphoria. And what we would do for managing opioid withdrawal, right, would be a detox largely with buprenorphine. What's really interesting is we typically see like a release of that dysphoria, anxiety, and irritability when we bring in that opioid use disorder in a pure opioid withdrawal. The combined state, we would expect that irritability and dysphoria would not alleviate. which is very, very interesting. So at the bottom of the slide, they're exploring the use of dexmedetomidine again to target, right? We sort of fight fire with fire in the withdrawal field, right? We have a withdrawal syndrome from a particular class of drugs, right? And we're going to use a more controlled related drug, right, to manage that withdrawal syndrome. And dexmedetomidine is a very logical target. Clonidine and lofexidine, some of us may not know what lofexidine is. This is a drug that's FDA approved specifically for opioid withdrawal and opioid use disorder. And this is an option for folks that want a non-opioid detox effectively from opioids. So because of the similarity in mechanism, there may be some opportunity there as well. And again, that would be tapered over a period of time, similar to what we would do for opioid withdrawal, 5 to 7 days typically.
Yeah, see, that's why it's so important. I really have been encouraging Dr. Avalos to get a detox consultation hotline, and I think you can get a hold of Dr. Avalos through the hotline. But you can imagine if you're trying to, you don't have an X waiver now, right? So you can write for buprenorphine. You think, he's on fentanyl. He's on fentanyl. Let's put him on buprenorphine or Suboxone, and suddenly they're not getting better. Normally you get someone with opioid use disorder, you wait until they're starting to withdraw, you start them on bup, and it's like the miracle drug, right? And but suddenly, these people are like getting more and more anxious, irritable. They said, I don't like this, and we don't know why. It's like, okay, buprenorphine should be working. So I think that's why it's important. We need to test for this stuff. Have you yet run across it, John? Or
Not yet, not
no?
yet. I have not seen this yet. And what was really interesting is a talk about a month ago, put on by the DEA and a number of other law enforcement agencies, and they were talking about some efforts that they've taken on in the San Diego area. There's a kind of high intensity interdiction effort there. And what they're saying is that xylazine has affected the Northeast, the central US. It's been detected in San Francisco relatively recently, but it hasn't quite hit Southern California. Oh, thank you. That's perfect. I'm sorry for stealing your thunder here, Mike. And it's maybe that's a positive thing, but it's not for a positive reason. And the reason being is economics. Because of our proximity to our southern border, that fentanyl and opioids are cheap and readily available. And because of that, there hasn't been an economic incentive to cut the drugs with xylazine. And I'll let Mike continue.
Yeah, no, and I was talking to Dr. Tomas Aragon, who's the CDPH director and medical director, and he basically was saying the same thing as Dr. Avalos was saying, that they had a national conference. All states got together about xylazine, and they said, California, you're probably still okay. And we've got this map, and it's partly because hallelujah, we're closer to Mexico and it's cheaper. So that we're not seeing it much yet, and we're on the lookout. But you know what? If you can't test it for it, we don't know when we say we haven't seen it yet. But we're not so far when we're testing. We're not seeing nearly as much, and I personally haven't heard of any. But we'll let you know. If we start seeing xylazine really starting to appear as well, because part of what our job is surveillance and public health. I wanted to just bring this up too. This is just a screenshot. When you Google buy xylazine, here it is. Look, you can buy xylazine online. It's not regulated, right? CDC does. I'm sorry, the DEA does not regulate it. And look at this first one's in Temecula, where you can actually buy xylazine. So, and this is, God, there were a couple, 2 or 3 pages of this where you can actually buy xylazine online. So I think it's going to probably come in because more and more people will get difficult. They're starting to be afraid of fentanyl, or they can't get their methadone, so they're going to go to the street stuff, and the users and the producers are going to probably see this and be able to copy what their peers are doing in the Midwest and East Coast, and start mixing it in. So it's a danger for sure, and we need to be aware of it. And we're really pushing on being able to have the hospitals test for xylazine. I don't know whether we probably won't have time, because we want to leave about 10-15 minutes for discussion or open forum. But one of the things in terms of legislation that's come out is the recent legislation that requires hospitals and labs where you order a generic drug screen to include fentanyl. It has yet to include xylazine, but then, John, you were going to share something about fentanyl testing. What was that?
Right. So, one of the things I do at DPH is I also function as a lab director for some of our substance use clinics. And so I've gotten to be a little bit of a lab nerd, if you will, as it relates to drug testing. And so, one of the issues we look at is what tests are available, right? And what tests are eligible for what's called a CLIA waiver. So what can be used in a very low complexity setting within the regulations. And I have searched high, I have searched low, I've asked friends in other places and counties, and there is not yet a CLIA waived fentanyl approved test. So what that means is, with this legislation mandating that testing, that would have to be under a moderate or even high complexity test. So it can be somewhat onerous. And my hope is that generates some pressure to move forward with tests that meet the regulatory requirements that are clear.
Yeah, we're still getting harm reduction kits that include fentanyl test strips, though, right, John?
Yeah, exactly. So that would actually be for testing the drug product rather than a biological sample. So yes, that would be for the folks who are still using to be able to test, and that is readily available. And one of the things we've also actually we placed an order for, but there's a backlog, is for combined fentanyl and xylazine test strips, so that folks know what they're using to make informed decisions before use.
Yeah, and I'm going to talk about harm reduction in a second. So that's important. And thanks for making that great distinction between CLIA waive tests and approved for fentanyl testing. It's really on body fluids.
That's right.
Well, because the fentanyl test strips that are out there are for testing their supply, the drugs. So important to know. So what we're going to do now is talk about, actually, I'm going to skip that one. When Dr. Avalos, John, if you can just talk a little bit about some updates.
Absolutely. So this is a lot of scary stuff, right? This is some doom and gloom and some very sobering statistics. But one of the things that we can do about this, and one of the things I spend a lot of time doing, is medication-assisted treatment. And so this would be offering really one of four medications. So methadone, sublingual buprenorphine, long-acting injectable buprenorphine, or naltrexone, either oral or long-acting injectable. And so in Lancet Psychiatry, very recently, June 2023, Degenhardt published this big meta-analysis, including a total of 276 studies that were both randomized controlled trials and observational studies. And they were looking at the efficacy of good old methadone, right? Tried and true maintenance versus buprenorphine in opioid use disorder. And they found a few things that were really interesting. So they did find that treatment retention was somewhat higher for methadone than buprenorphine. What they found also is that buprenorphine receiving patients demonstrated comparatively less use of extramedical opioid use than those on methadone. And this is really interesting, right? Because folks know how these drugs work. The folks with use experience and lived experience the blockade of the opioid use, or excuse me, of the opioid receptor and the binding affinity is much higher with buprenorphine than methadone. So what that means if you're on buprenorphine, you are not likely to receive any euphoria or effect from use of an illicit opioid on top of that. That is not the case for methadone.
Yeah, and I think that what's important, and I've actually had some experience in MAT clinics as well, is that people can work and drive when they're on buprenorphine, but I don't think if they're on at peak methadone levels, they can really function that well.
It can be challenging if the doses get higher, but the other part is the mechanism, right? So how can we deliver buprenorphine? Well, any one of us here with a medical license can prescribe buprenorphine. Now, the X waiver has been eliminated. Methadone under SAMHSA and other regulations can only be delivered through a methadone clinic, right? For opioid use disorder. Now, that's not to preclude pain. That would be a separate conversation. But for opioid use disorder, maintenance has to be through a certified NTP or methadone clinic.
Yeah, and the methadone clinics it's so onerous. They have to go and line up every day for their medication.
I would have a really hard time doing my job if I had to do that every morning, right?
Yeah, exactly. Excuse
really
me, I'm going to be late. There's an extra long line for methadone today.
Right. So it's tough. And the other thing is it can be stigmatizing. And as I've been serving younger and younger patients in the adolescence, sometimes it's not a great environment for a young teenager who's maybe 16, right, to be in some environments where there may be elements that are not favorable for that young person. And so that can also kind of guide some of our decision making. Yeah. One of the other things Degenhardt, going back to the study, found is there was a higher patient satisfaction in those receiving buprenorphine. There was actually reduced anxiety, and there was a lower incidence of cardiac dysfunction. And I think that this may go back to the difference in the effect on QT prolongation, right? Sometimes we forget, right? Methadone prolongs the QT, right? As does buprenorphine, but to a lesser extent. One thing that was really interesting, favorable for methadone, is that Degenhardt found that there was actually reduced alcohol cravings in the methadone group and a reduced incidence of hospitalization. So some very interesting findings from a very large trial published in the Lancet.
Yeah, and I think when we get to our expanded session on MAT, I think one of the things as an emergency physician that was really troublesome with methadone is its pharmacokinetics. The higher the dosage you're on with methadone, the higher the morphine milligram equivalents are, so that when you just jump 10 milligrams, sometimes your morphine male equivalents go up by 4 times rather than just 2 times. And so it's pretty dangerous, don't you think?
Well, and right, and I think since the 70s, this is exactly the reason why there's been this extremely cautious strategy around initiation of methadone, which I think is justified. My understanding of that, Mike, is that there's a dissociation between the clinical effect in terms of mitigating opioid withdrawal and cravings and the effect on respiratory depression, right? And the concern is if you're only following symptoms, you can have a big surprise in terms of produced respiratory depression a few days later when you receive full effect. Right. So this is exactly why the federal regulations, they cap the doses when you're initiating methadone specifically for this reason.
Yeah. And actually I'd love when we have our expanded session just to talk, because buprenorphine is an agonist antagonist and methadone is pure mu receptors. Buprenorphine is mu and kappa, I believe. So that actually the buprenorphine doesn't have nearly respiratory depression that methadone does.
That's right.
So
that's right.
So good points. And
so this is I love this goofy picture of this very concerned doctor. And a lot of times, what our experience is, right, for those of us that have been around for a minute, maybe we completed our X waiver training, right? We needed some CME. We thought it was an important thing to learn. But then we have this reticence or this reluctance, right, to move forward and actually prescribe. And this is exactly what my face looked like right? As I'm making that decision to be, am I going to be the first person to prescribe buprenorphine in that clinic, right? What's been so cool about working in this field is that this is a team sport. There are not a lot of big egos in the treatment of addiction, right? There's no time for that. And so I found that this is an incredibly collaborative field to be in. And there are a lot of resources available to you for mentorship and coaching, particularly before you write your first buprenorphine prescription, and maybe even as you're going through your very first patient. So if you look around this virtual table, the peers and colleagues that you have in the San Bernardino County Medical Society, myself, Dr. Sequeira, and many others would be very happy to take your call, to work with you, to talk you through an individual case. There's a buprenorphine warm line. So UCSF operates a warm line, and I hope that you're all able to take out your phone and maybe take down a few numbers. This is one that's in my phone. And I've actually called them. I've had some very complicated cases that were not covered in my training, and there is no literature about the particular question I had. So, phone a friend, right? Addiction is a team sport. Addiction medicine is a team sport. So I called UCSF. They called me right back within about 10 minutes. Again, it's not a hotline where they're going to immediately pick up. It's a warm line. They'll call you right back generally within a short period of time. And they'll have a very bright person who can help guide your decision-making and function as a sounding board. I mentioned testing and toxicology. Sometimes situations come up and we have a question about drug testing, right? The patient is testing negative for benzodiazepines, and yet they're showing, this symptom and that symptom, and I know their history, right? I'm not seeing something, right? And right when the hair stands up on the back of your neck, and you just know something ain't right, you can call poison control. And this is there are really two. There's like a bifurcation in poison control. There's poison control for consumers, right? Right. My toddler, drank, I don't know, soap, right? What do I do? And that's fine, and that's important. But there's actually a provider line for medical professionals, and I've called them. And I've had guidance on more sophisticated testing and toxicology that was beyond my training or expertise. And the particular toxicologists, for whatever reason, working poison control tend to be emergency physicians, and they tend to be incredibly helpful. So please take down that number. And if you have questions about toxicology, it's a phenomenal resource. One of the other things I want to mention, and I think to some extent I'm preaching to the choir here, but the California Bridge Project is incredibly helpful. This has been one of our biggest successes in the last 5 years within our local system of care. We have 7 hospitals participating and more to come. So if you click on this link here, Bridge to Treatment, and click on Shift, this is really for folks that are working in an ER or in an acute care setting, who are interested in inducting a patient on buprenorphine. There's a very well-written flow chart on exactly what to look for, what to monitor for, and what doses would be appropriate. There's also a phone number that can be very, very useful. And what's so beautiful about this, right, is that this is a 24-hour solution, right? If somebody has an opioid issue, 3 a.m. on a Sunday, they can roll into a participating ER. They tell the triage nurse here for the Bridge program, right? Generally, these clinics are specifically trained, or these hospitals are set up specifically to be destigmatizing, right? And that person is basically fast-tracked into a monitored bed where they are given drug testing, evaluated, and they're inducted on buprenorphine. Doses are titrated. They can come back for up to 3 days, right? And then they are, probably the most important part is they are connected through a substance use navigator to a receiving clinic such as the ones that I operate.
Yeah, and I actually was the PI. I started the Bridge program at St. Mary's, and I know that there's, as you had mentioned, others. Arrowhead Regional, St. Bernardino's, Loma Linda, among others, have Bridge programs. But this is big, and many emergency departments and hospitals have gotten the grant. Public Health Institute, PHI, provided grant funding for every ED in our county to be able to start a Bridge program. So I'm really hoping to start up what we call a COP, or community of practice, where we can actually meet once a month, or just PRN, and discuss our issues. But the bridge project, the number John gave you, and the website is amazing. They've got it's got every toolkit and protocol. So and some real big experts. But we have a lot of experts, like Dr. Avalos. Actually, I've induced probably close to 100 uh, patients just between the ED and working in an MAT clinic as well. So it's big. And one of the things that I learned when we started working with substance use disorder in the Bridge program was this whole concept of harm reduction. And when we started bringing people into the ED, who needed help, John mentioned the stigma. So the nurses, we had problems with the nurses and the docs. They're saying he's just here, he's a druggie, and he's just here for more drugs. He wants opioids, and so one of the things that we have to do is stop this war on demeaning patients, because you know what, they're not going to come in for help if they're stigmatized, if they're going to be shamed, if they're going to be made fun of, have their nose rubbed in the ground, they've got to be either really, really wanting help. But 80% of the ones who come in wanting help, if they're shamed because of the stigma, they're going to walk out and they're not going to come back, and then they're going to die. Either that, or they're going to feed the chain in terms of that. So I learned really importantly about harm reduction, and I can't preach it enough. John and I have been talking about the acceptance of this, and one of the basic principles of harm reduction is just this number one bullet: accepting that there will be at least experimental use of, name it, okay, fentanyl, alcohol, Xanax, or whatever. It doesn't reflect it's not a character flaw. It doesn't stamp a person as a low life because they do that. And part of what we'll be talking about with substance use, there are specific areas in the brain that predispose to substance use disorder. The nucleus abducens is one of the. So there's sources in the brain, and it's biochemical. Is within the brain as well. So it's a disease, and that's the whole key uh, of recognition here, is destigmatizing. It's not a character flaw, okay? It's a disease, and just like, and I've got this rote kind of memorized statement. It's just like you wouldn't persecute and make a diabetic feel bad for requiring insulin. Uh, you really shouldn't uh, uh, put down someone who needs buprenorphine uh, or naltrexone for alcohol use, or any of the other MAT agents as well. So there's no way that we're going to get a hand in a handhold of this whole issue of substance use if we don't act more in the harm reduction philosophy of destigmatizing, recognition of that this is a disease, uh, uh, basically recognition and validation of the goodness in that person through motivational interviewing, like Dr. Avalos has talked about. So we all need to do this. I had to really get it into the nurses. I had to get it into the docs who did, in the ICU docs, the pulmonologists, et cetera, that this is a disease, and we're in a battle, and everyone's got to get with it. Don't use terms like addict, abuse. All those kind of terms are basically adding to the stigma. And you don't want to call, if you're just imagine your daughter or son, you don't want them called an addict or an abuser. And that's so important in this harm reduction philosophy. And just know that it is a disease. Use the disease model of substance use disorder, and treat it like a clinician, like a scientist, like a compassionate person. That's in all of us. Okay. And then a part of harm reduction is not just the benefits of naloxone, but we have funding for HIV for harm reduction, and it's all like needle exchange, and so it under harm reduction is also test strips for fentanyl, as well as hopefully Xylazine down the line. So there are further principles, and John, you want to take this one?
Right, absolutely. So this is kind of a visual depiction of what does harm reduction actually look like. And I saw in the chat, and I love this, what Mike said, is the words matter, and treating people with compassion. In my experience, it feels a lot better than spending a shift shaming people, right? I go home a lot happier. And what I also find is that, from a practical standpoint, we have to be better than the competition, right? And the competition is a street level dealer. So I have to be kinder, more understanding, build better rapport. I have to have better pharmacologic options for that individual, right? And I have to be flexible and available. So if there's a missed appointment, well, you know what, John, you don't get to have a conniption fit about it, right? You have to be flexible and understanding. So that's all I'll say about that. But in terms of the pictures we see here, so here, if you haven't seen this is Naloxone nasal spray. It's available at zero cost. You don't even pay the shipping for that if that comes from DHCS, Naloxone Distribution Project. We see fentanyl test strips here in the second image. And this is, again, to Mike's earlier point, this is actually used for testing the drugs or the pills or substance before use to determine whether or not it contains fentanyl. And this has been actually from a 2018 study at Brown University shown to result in safer use patterns. And specifically what that means is using less of a substance and using in lower risk situations, such as not using alone. That brings me to the third image here. This is a new resource that we're bringing, which is a hotline nationally. So this is another phone number that you may want to save in your phone. This is somebody for one of your clients or patients who still continues to use if they're not ready to stop. The deal is, look, I care about you. Please don't die. How are we going to prevent you from dying? Well, we're going to get you these resources. Naloxone, we're going to get you test strips. And if you don't have somebody to use with, I want you to call this line. What this basically is kind of like a 911 operator, right? First question they'll ask, I've actually called them last week to test it. They'll ask your location, and it's just a person with lived experience who will sit there with that individual and will call for help if that person becomes unresponsive. So that's a new resource. And then the last resource here is the DTERA drug disposal pack. So not all opioid use or substance use is illicit, right? Some of this is medication that's expired, right? If you're like me, you may have a multi-generational household, right? You have, grandma's pain pills, and then you've got a nephew visiting, right, who's curious and gets into everything. If someone's able to dispose of their medication, they no longer need safely and conveniently or illicit drug products. It's just not around for accidental exposure, right? So that's another part of harm reduction. Thank you.
Yeah, great. And
I just jump in really quick, both
Sure.
of you. I just want to remind you of the time because we have lots and lots of questions and
Oh,
comments.
great.
So one of the things, it's 1:21 already, and we end at 1:30. So Daria had a great idea. If you'd rather, we can summarize, take those questions and email them to you. But I don't know if you want to try to leave room for.
No, well, we can do that now. And I wanted to mention that Narcan is now over the counter, and the problem that we're having is it's $45,
Yes.
which homeless person has $45 to buy it. So we're trying to get it free. So the rest of it, and I know I know somewhere in that chat, I haven't seen it, they're going to say, can we have the slides? So yes. So yes, we got clearance from DPH and Department of Behavioral Health and Department of Public Health to release these slides to our wonderful staff at Medical Society, and they'll be able to send out to people. Quickly, just resources. There's the Inland Empire Opioid Coalition. The Medical Society really helps to start this, and it's administrated by DPH and DPH and Arrowhead Regional and all the hospitals, Loma Linda, Kaiser, everyone's. If your organization wants to join this, you're in. It's inclusive. Okay. There's the CDPH campaign. If you go to their website, there's lots of resources on this. This is from basically the Department of Behavioral Health. I'm amazed at how many resources DBH has, and this is their 24-hour hotline, helpline, and substance use disorder helpline. And what I love about this is you don't have to have insurance. They'll get it for you. They'll get you help. So that's cool. And then the last page is just these resources that
Wow.
so there's all kinds of stuff. This presentation is so full of good information. So I'm going to stop sharing now. We can open up. I don't know if people want to just unmute and do it that way, or
well, why don't we, Sequeira, why don't you jump in? I think Dr. Pai has the first question there. If we go back, way back up in the chat and start with that, and then we can get to hands raised.
Perfect. Okay. The first one is, what are we doing to prevent availability of these drugs?
Right. So this is largely a law enforcement and DA related topic, but some of the laws have changed actually. And one of the big deterrents is that the DA in our county is actively pursuing homicide charges for folks that sell or distribute drug products that result in a fatal overdose. And there's a precedent for the DEA to do this as well. And so I think that's a big deterrent. I think that there is collaboration between something called the HIDTA, the DEA, and local law enforcement as well, to track the avenues of distribution for this. But going way beyond that, that's the supply side. On the demand side, our departments actually work closely together with something called Friday Night Live to educate young people, kids in school, about these drugs, about the changing drug supply and the risks involved, and really to provide sober, non-substance related avenues for having fun.
Yeah. And just to mention that the sheriff's department has an overdose response team, but they're going for supply, and our DA has started a whole task force on fentanyl education as well. So they're really going after Assemblyman Ramos is introducing a bill on making fentanyl possession a felony, and also selling for that ends up in death, overdose, felony as well, of course. And the other thing is, the sheriff's department recently released, they've actually seized over 2.5 million pills of rainbow fentanyl, just San Bernardino County. So they're on it, but that's why we need harm reduction, just accepting that it's there.
Wow. And Sequeira, why don't you skip my question and go to Cindy's?
Okay. What have you learned about the reasons behind the OD growth in 65 and older groups?
Right. So my sense of that from working in the clinics is that a lot of this has to do with the drug supply changing. And I would add the essential vulnerability of being somebody who's 65 and older, right? Somebody who may have comorbid cardiovascular or pulmonary disease. That's somebody who may not have that pulmonary reserve, right, to cope with the exposure. That would be my sense of that. That's definitely something that I will be watching closely for. And I think the CDC will be investigating that further.
Great. How about the use of illegal drug use due to non-availability of legal drugs?
Yes, this is where MAT comes in. So one of my favorite presentations to give, this was phenomenal, Mike. You did a great job. This is great. Back in the day, right, when all we had was the data from California Department of Public Health, there was a bifurcation that I love to point out. And the bifurcation point, it was a split between the number of morphine milligram equivalents prescribed and buprenorphine prescription, right? So there's a separation of that. And so a lot of times we hear the clinical story, right? I busted my ankle, I had spine surgery, I fell off a ladder. Okay, got started on the medication, I had a pain issue, right? Transitions into a use disorder. And what's important is not to abandon that patient, but if there is a use disorder, either treat that person with medication-assisted treatment if you feel comfortable and able, or refer them for treatment, right? And what's interesting about the partial agonist MAT or agonist MAT is that there's also a benefit in terms of pain. Buprenorphine actually has a second indication that we often forget about, which is pain. The third point I would make about that is don't overlook interventional pain therapies as an option. Injections, ablation of nerves, and really getting creative to go beyond just the prescribing when the prescribing is no longer optimal for the client.
Yeah, and I think that whole issue of treatment of pain and chronic pain, we learned a lot about it, and the anesthesiologists have an amazing approach. They can put in, they're opioid inhibitory pathways in the spinal cord, and they can actually put in stimulators to actually in that spinal tract to actually inhibit perception of pain. So there's we call them altos or alternatives to opioids. We'll do a whole session on treatment of pain and chronic pain. Low dose naltrexone is another thing that I've recently learned about. Naltrexone is the Narcan but long acting, and usually the pill form is 50 milligrams, but low dose, like 1 to 5 milligrams, has been shown to be very effective for chronic pain. So, yeah, we're getting. I think Artenica says, please do a session on pain. That's definitely part of this.
Yeah. So Maria, you can skip mine. Go to Carolina's.
Okay. Is local data available on nitazines?
Nitazine.
Yeah. And emerging opioid spread. Go ahead.
Is it okay if I comment on that, Mike?
Absolutely.
Yeah, please.
That I have available. So this is an alternative, right? When we regulate an opioid and a synthetic opioid and the derivatives of that synthetic opioid very, very tightly, the drug supplies often transition to alternatives. Nitazine, specifically isonitazine, was one of those, right? And so this is the cat and mouse game between regulators and illicit drug manufacturers and suppliers. The local data on nitazines is not as robust. And I don't have that off the top of my head, to be honest with you. I think it's something that's really worth watching as the regulations tighten the supply on fentanyl, and we have to wonder, where's the supply going to go? Is it going to be a xylazine fentanyl or a xylazine nitazine? We'll see. This is something that we haven't seen a huge amount of in California, but the forensic toxicology folks are monitoring for this. That is something that's been tested for.
Yeah, great point. And thanks for bringing that up, Carolina. That's about nitazine. We hopefully won't have to present on it, but we can maybe do that.
Do you want me to keep going?
Yeah, let's keep going.
Okay. All right, let's do it. What extensive drug screens would you suggest to use to test for these?
Go ahead, John.
So, I would go for it. There's something called, depending on what lab you're with, there's a option with, I think, most labs that's a drug screen with reflex confirmation. And I think that second part is the most important. And so without wasting a bunch of time going into how they work, the risk of that false positive caused by the ELISA screens, right, kind of a mismatch, is eliminated with that. So you're much more likely to get precision testing and precision answers that you actually need. In terms of the exotic drugs that we're talking about, the xylazine and the emerging nitazine drugs potentially in the future, that's something that may require a conversation with your lab representative to see if we can get that. And that's something that I think Mike and I will be probably working together on to see what our commercial labs have available and advocating for inclusion of those tests, not just in a research setting, but actually to be clinically available if the test contractors
yeah. So there's so much. I love the enthusiasm and interest, and I think we're going to probably need to stop here. But I'm actually I'm all jazzed up for doing more because I think the community and hopefully everyone let everyone know. I mean, this is good stuff, and we've got experts like Dr. Avalos here that I'm always excited about working with Dr. Avalos because he's so smart, but he's tuned in and stuff too. So it's great. And again, thanks to Allison and Janice and Soteria and the Medical Society for allowing this. And please, as your health officer, I want as many people on this as possible because I'm a firm believer that physicians need to take physicians and the medical community need to take charge in this, and we want to do everything we can to help you do that. So.
Well, thank you both so much. That was absolutely phenomenal. And we look forward to the rest of the series as well. That's going to be really exciting. And just a quick reminder, Janice did put in the chat how you can apply for your CME credit. There's the QR code in the application form right there. It also is in your email already, and we're going to send it out again. You have to do it by 5 o'clock today. But we will keep you posted on time and date for the next in our series. And Dr. Sequeira and Dr. Avalos, thank you not only for being here today, but for all this transformational work you're doing to really make our entire society so much healthier and approaching this in a contemporary way. So thank you, everybody. Have a great rest of your afternoon, and we'll talk to everybody real soon. We'll see you next time.
Thank you so much.
Thank you.
Goodbye.
Bye.